And now let's begin our broadcast with a look at infection control. Based on recent statistics, some hospitals have been challenged by trying to reduce the risk of infections associated with medical equipment, devices, and supplies. An organization that has undertaken several initiatives related to infection control is Riverview Hospital Association in Wisconsin Rapids, Wisconsin. Operating a 99-bed acute care hospital and several clinics, Riverview remains one of the few locally owned community health care providers in Wisconsin. Their commitment to reducing and preventing infections starts right at the top of the organization.
Our board of directors and leadership team has made a purposeful decision that we will have a culture that values the provision of high quality, safe care for our patients. We operationalize that decision by ensuring that we've adequately staffed the areas of performance improvement and infection control. Then we have further ensured that through the articulation of expectations of the importance of high quality patient care at the point of hire, and then we have a process of monitoring performance and providing feedback through the reporting of data.
Well, our quality improvement approach at Riverview Hospital is a Lean Six Sigma framework. We implemented that about 3.5 years ago, and we've been consistently trying to grow our expertise in the area and use of tools within our day-to-day operations. We monitor a lot of data in general, but we certainly monitor a lot of things related to infection control, both process measures and outcome measures. So on the outcome side, we certainly look at infection rates. For all the various types of infections, whether those are central line infections, urinary catheter infections, or surgical site infections, would be some of the things we would look at. And then process measures that we look at our healthcare population, both of patients and of our healthcare workers. We look at immunization rates for those folks. We also look at hand hygiene compliance. Look at things such as documentation around why we're inserting a urinary catheter. We look at documentation around when do we use shortened cycle sterilization and what were the circumstances around that. So we look at both process and outcome, and that helps us to determine where we might need to focus projects and work in the future.
The way that we are able to effectively implement infection control practices here is to use our infection control plan as a living document. We use our infection control plan and risk assessment to really guide us in our decisions when we're trying to look at our program here. And what this really means is that we don't do the minimum requirement that we do the infection control plan and risk assessment once a year and use it as a checklist, that kind of a thing. Yep, we've done that. We really use it to guide how we make our decisions.
Riverview's infection control plan helps define the work of their infection control committee.
Our infection control committee is a multidisciplinary committee, so we have all key stakeholders there, whether they are members of lab, the medical staff, nursing, infection control, quality improvement, employee health. Everyone sits around that table. And we really have tried to harness the expertise that those folks bring to the table.
One project they've been working on is the reduction of catheter-associated urinary tract infections.
In 2009, we gathered all of the best practices and evidence-based guidelines that were out there and performed a gap analysis just to see where we were at and where we needed to be and try and close that gap to make us best practice. And it took us 9 months to get everything, a lot of logistics involved in that sort of thing, a lot of departments, a lot of people, to try and make us best practice. And what we have found is that we went live January 1st, 2010, is by implementing the evidence-based guidelines and the best practices, we were able to reduce our infection rate, our CAUTI rate, by 78%. We've retained an estimated $5,000 from CAUTI prevention. We've increased our SCIP-9 compliance tremendously. We have reduced our device utilization by up to 65%. And we've been recognized by many people for these interventions, and our staff are really, really proud of the results that they've worked so hard to achieve. I can't say that for sure there was one thing that made it just spectacular, because there were a lot of little things. We needed to have a reason why you were going to implement or why you were going to insert an indwelling urinary catheter. It couldn't just be for any reason. It had to be a specific reason. We had reminders for physicians. What we found when we pulled physicians is sometimes they didn't even know that their patients still had an indwelling urinary catheter in. So we had reminder systems. If they wanted to keep it in after 24 hours, they now have to reorder it and tell us why. We looked at our device. So is it a closed system? We didn't have the entire system in a closed container so to keep it sterile. So we looked at that. We looked at our nursing documentation. Instead of just a timestamp saying, you know, I checked on the patient and I cleaned appropriately, or I took good care of the catheter, we broke that down. We looked at the evidence-based guidelines and we said, now, is this documented somewhere? Is this documented? And if it wasn't, we made the documentation there.
Staff in central sterile processing have also been involved in projects, including the hiring of qualified staff and the reduction of immediate use sterilization.
One of our greatest challenges through the years has been hiring qualified staff that are engaged in infection control. Overcoming that, back in about 2007, I was approached by the local community college. They noticed that we had a need for central service technicians in the area. We have other hospitals as well that were experiencing the same problems that I was. So they asked me to come and help them develop curriculum for the central service program. So now they have this program. We're graduating 10 students a year. Those students come to us ready to work in central service. They've got the basics for infection control. Most recently, our processes that we've been looking at are related to the immediate use sterilization, because that's been real hot now. And recently we developed a form for reporting the immediate use sterilization. The surgery department uses this form to fill out when they sterilize something. Then the form comes to the sterile processing department and we electronically enter the information. So we needed a form that was consistent when we had all the information on it. So that was one project that we worked on.
Two additional projects involve a newly acquired dental clinic and the reduction of surgical site infections.
And what we wanted to do was look at the dental clinic, especially with regards to their sterilization and disinfection of their dental equipment, and ensure that they're following manufacturer's instructions, that they're following infection control best practices. So we went over there for a few visits and talked with the staff, looked at the infection control guidelines for the dental facilities, and looked at the manufacturer's instructions for their sterilization and disinfection of the equipment. And what we did is we were able to make policies for them regarding employee health, for significant exposures and that sort of thing, infection control policies, and then policies for disinfection and sterilization for the staff to follow. Recently, we've implemented where the surgeons have to use a preoperative skin prep that has chlorhexidine plus alcohol. Using the antiseptic plus alcohol has been shown to reduce surgical site infections by up to 40%. And so we've been I just started the audit process, and we've been about 100% with that, compliant with that intervention. We are looking at, for our joint camp patients, so for those who are undergoing elective hip and or knee surgery, implementing where they're going to be bathing with a chlorhexidine bath, washcloths for 3 days prior to surgery. And then we're looking at implementing a process where we're going to swab those patients for Staphylococcus aureus to identify them and see if they're colonized with the organism, and if they are, we're going to decolonize them, because both those things show that we can reduce surgical site infections.
Along with such projects, another key component of Riverview's infection control efforts is ongoing staff education.
Every year we have what's called an infection control fair. It's 2 days all about infection control, where staff are required to come visit with us. One of the things that I like to present there is the new interventions that we've implemented and the results. I found that staff really, really like those results.
The payoff for these efforts is increased trust from their patients.
Well, it means that they can come to the organization and they can trust that they're not going to come in and leave in a worse state than they came to us, certainly, and that they can trust that we're going to do the right thing and we're not going to do anything that would potentially put them in at harm or at risk for harm. So I think that's a real sign of encouragement, and when they entrust us with their care, we want to make sure that they're getting the highest quality care that we're capable of providing in an organization our size.